Hello and welcome everyone. Thank you for joining the National Association of Pediatric Nurse Practitioners for our webinar entitled Back to School TB Screening, What Practitioners and Families Need to Know. This program is supported through an educational grant from QIAGEN. At the conclusion of today's program, all participants will be asked to complete a brief survey. Those that complete the survey will be eligible to receive a NAPNAP Certificate of Attendance. This continuing education activity is administered by the National Association of Pediatric Nurse Practitioners as an agency providing continuing education credit. Individuals who complete this program will be awarded with one NAPNAP contact hour. In order to view the survey, your pop-up blockers will need to be turned off. At this point, it is my pleasure to hand it off and introduce our two speakers for today, starting with Scott Lindquist, MD, MPH. Dr. Lindquist completed his medical training at the University of Washington School of Medicine as a student of the Washington, Alaska, Montana, and Idaho program. He completed a residency in pediatrics at the University of North Carolina at Chapel Hill and an infectious disease fellowship at Baylor College of Medicine in Houston, Texas. He completed his master's in public health at the Harvard School of Public Health. Dr. Lindquist has drawn upon this broad background to focus upon underdeserved populations and infectious diseases. He has combined all the aspects of his training as a health officer and director of health for the Kitsap County Health District since 2001. In addition, he serves as a pediatrician and public health officer at the Port Gamble Sklallam Tribal Medical Clinic, where he has worked 1 day a week since 2001. He also serves as a tuberculosis medical consultant for the Washington State Department of Health, a position he has held since 2002. Our second speaker for today is Kim Field, RN, MSN. Kim Field is a member of National Tuberculosis Controllers Association since 1994 and served on the executive board as president in 2004. Currently, Kim serves on the national board of the Stop TB USA. She held the position of tuberculosis controller of the Washington State Department of Health from 1996 to 2011. Kim served as an affiliate clinical faculty for University of Washington School of Nursing, and with this affiliation, she served as a consultant to the University of Washington for the NIH-funded National Tuberculosis Curriculum Consortium from 2002 to 2007. She has also invited faculty to the Francis J. Curry Regional Training Center in San Francisco for the TB Case Management course. Her publication work includes 3 publications and collaboration on publications with 16 co-authors and is cited by 82 authors. Kim received her Master's of Nursing in Advanced Practice Community Health from Seattle University in 1997 to go along with her Bachelor of Science degree in Nursing from San Diego State University back from 1971. She has lifetime certification in public health nursing and standard services credential and a school nurse for the state of California. Today, Dr. Lindquist and Ms. Field will present Back to School TB Screening, What Practitioners and Families Need to Know. Welcome, Dr. Lindquist and Ms. Field. The floor is all yours when you're ready.
Great. Thank you for the introduction. This is Scott, and of all those things that he introduced us on, which is lengthy, but probably the most interesting thing is I have a kid going off to college this year, and this whole issue of whether she should be screened for TB comes up both from her practitioner and from the college, and we'll go through that. Kim and I are going to have a discussion centered around a lot of these slides, and you can see the learning objectives here, that we're going to apply the American Academy of Pediatrics guidance to screening kids for tuberculosis, and we're going to review what the CDC and the American Academy of Pediatrics actually recommends about the tuberculin skin test or the interferon gamma release assays. And then we'll discuss the pros and cons of using the skin test or any blood test method like an IGRA in testing those kids as they go back to school. So today's outline, you can see here, we're really going to have a couple questions posed throughout, some slides that will help give some background on this, but more than that, Kim and I are going to have a discussion. Kim and I have worked together for years, and you'll hear us share some of our experiences in this back-to-school screening. So with that, I'm going to introduce Kim.
Hello. Thank you, Scott. And yes, this is certainly an important topic for all of you practitioners listening in and for the time of the year and looking upon the children entering school at this time. I found it interesting, Scott, mentioning his daughter entering college, and I remember when my son left Washington and went to California going to school, he was asked for a tuberculin skin test, and he told them what his mother did for the state of Washington, and he'd never had one because Washington State had years before had really done away with the administrative screening of children, and that's one of the our first topics on today's outline is why are children screened for TB upon school entry. And for this, Scott and I, can discuss that is an administrative screening, but certainly in today's world and certainly with what we know with tuberculosis in children, we really need to do risk assessment and really determine if the child is at risk rather than have these broad use of resources to screen children that really don't need to be screened.
Yeah, I think most of the reason that kids are screened for school entry is one of the two following main reasons. Number one is it can be an administrative requirement for a school or a college or a university, or it can actually be that these schools have high-risk kids in them, and so screening kids based on their risk in different parts of the country makes sense. So what we're going to talk about is really trying to get us all as practitioners educated on the facts. So docs and nurse practitioners and nurses and parents all understand who really should be screened and try and put the brakes on some of these administrative requirements for screening upon school entry. So the real question becomes who's at risk for TB and who in the United States is at risk for TB as a child. So one of the things we want to do is just give you some of the background on, and for some of you may be very familiar with this data, but others may not. So what I want to point out here in this first slide is the number of cases, of TB cases in the United States has been steadily declining. You can see a little bit of a bump here in the late 80s, early 90s, and that was, of course, associated with an HIV epidemic and co-infection and lots of cases in New York City. But really, the trend for tuberculosis in the United States has been downward for years here in the United States, which is good news. It means that we are doing our job. But the United States is not all equal. There are certainly parts of the U.S. that have higher case rates than the rest of the country. So we're looking here at a map of the U.S. with certain states in blue that have higher rates than the national average. And you're looking at these states like California, Texas, Florida, certainly New York, Washington, D.C., Alaska. And these states have a different state rate than others. So certainly here we're sitting in Washington, we're usually at or below the national average. So it really requires us to look at our epidemiology of our own state.
That's right, Scott. And after my retirement from Washington State in 2011, I did move back to my birth state of California. I worked in two counties, one a border community and one central to California. And I must say that in both of those counties, the case rate and morbidity was higher than the state of Washington. And in one of the counties, it was a prime area. I had never lived there before in the central part of California. It was a prime area for new immigration. And so right now, currently in that county, there is an outbreak in a high school, and it certainly reflects the diversity of the groups that have immigrated there. But I must say, and in all of this you'll hear me or maybe Scott allude to, that in this particular community the public health infrastructure has been eroded by lack of resources, and so then there are reasons for outbreaks. In the other community of being a border community, Across in Mexico, I mean, we don't get the reports necessarily. We don't have the epidemiology in other countries as we do here and with CDC. There are many cases even of XDR being treated. Thankfully, those aren't being imported into the U.S. But we have many families that live in Mexico in the community I was in and go to school and work in that county. So we have high levels there. So those are just some of the examples when we talk about the high burden areas.
Yeah, and I think for all of you on the webinar, it's really important for you to understand your local epidemiology, both in your state or in your county. So as a county health officer, it's always helpful to know, and Kim's right, a lot of the epidemiology of tuberculosis nowadays is being driven by your immigration patterns. And so in my county, 100% of the cases are in Filipinos that have immigrated into the county. We are a military county that has an affiliation with the Philippines, and so therefore we have to understand TB of the Philippines. Now that'll be very different than other parts of our state where I also do consulting and where there's a large amount of migrant farm workers. We have to understand the flow of migrant farm workers. We have to understand the flow of foreign-born adoptions. So that's something that you need to understand for your community. And the other point here is that not all TB is the same in different age groups. And we're talking about kids today, which has one of the lowest TB case rates of all age groups. The highest age group, of course, being those older than 65. And the reason why I point this out is that case rate in folks older than 65 is due to a couple reasons, but I affectionately call it a failure of the public health system to catch these infections when they were younger. So a person could have been infected when they were 5 years old or 4 years old, lived with an infection for years, and then becomes a case as their immune system weakens or they're older than 65. So really looking at our talk today, what we're trying to prevent is this highest case rate in the 65 and older by identifying people that are infected now and treating them to make sure that they're not a case when they're older. So case rates for kids tend to be a little bit lower. And if you look at the percent of pediatric TB cases by the age group, not all the ages are the same. And this is a very interesting phenomena in kids. It's that age from 4 and under that tend to have the highest number of cases. And that's, of course, due to a lot of natural history studies which show us that when someone's infected, which means they breathed in the bug, and they've got either a positive skin test or a positive interferon gamma study, but their chest x-ray is normal, they don't have any evidence of disease, we call that latent TB infection. Now, classically, 10% of the folks that are infected that have latent TB infection go on to have disease, which is exactly what it sounds like, a pneumonia, a lymph node, you name it. But what's the interesting fact for children is nobody progresses from infection to disease as fast as those kids under 5. So the 1 to 4 age group, higher than any other population, higher than someone with HIV/AIDS, higher than someone with diabetes. It's these kids that are 5 and under, once they're infected, that have a high percentage of progression to active disease. That explains here why we have such big burdens in the young age group.
I might mention, too, on a family case, a part of an outbreak in one of the counties that I recently worked in, not only, as Scott has said, that these children exposed, will have the higher rate of developing disease, but serious disease. There was one child that was 12 months of age that went undiagnosed for probably 3 months that ultimately developed meningeal TB and was permanently going to be impaired even with feeding tube and non-ambulatory status. So it is serious when we speak of these cases.
So what we're really trying to set you up by the end of this talk is to be epidemiologists. We want you as a clinician to be an epidemiologist first. Before you go in to see that patient, you understand the epidemiology of TB in your local area. You understand the age of your patient and what their risk for TB is. And we're going to build some other indicators for risk here that'll help you. This one here is a nice graph of the TB cases by race and ethnicity. And as you can see, the Hispanic curve at the top is higher than some of these other slides, which is indicative of immigration or other local communities. But the fact of it is that they have higher case rates by race and ethnicity. The next is black or non-Hispanic blacks in the U.S., and that's disproportionate. So that's really the fact that this slide shows you that TB is not an equal opportunity infector. It infects certain races and ethnicities at different rates. So again, I affectionately call it the clinical epidemiologist that you're all going to become by the end of this slideshow. You as a clinical epidemiologist should really have this in your memory banks.
And remember, this data should be available wherever you reside within either your state health department or your local health department, and should be readily available upon either online or requesting it.
This next slide, for all of you clinical epidemiologists, is really one of the more important slides. And what this shows in the lighter colored boxes, this is the number of and percent of pediatric TB cases by U.S. born. And you can see those numbers are decreasing from 1993 to 2012. The number of pediatric TB cases in U.S. born kids is going down. Great. We're doing a good job. What stays somewhat stable with little less decrease is the number of cases in foreign-born folks. Now, this should not be a surprise to most of us on the phone. TB is really a global disease, and we know the rest of the world has higher rates in certain pockets around the world. And as people come to the United States, which is one of our strengths, we're a country that lets people immigrate. My grandparents came here from a different country. Thank goodness. But if they come from an area that has higher rates of TB, it can become a TB burden for the U.S. And so what you see here in the pink line is that the percent of foreign-born is actually stayed pretty constant and is actually increasing in most communities, including the United States. And I alluded to this earlier. In my own county, nearly 100% of all our cases right now are in foreign-born folks. So as that clinician going into the room looking at a Hispanic kid under 5 who's here in your office, it should ring some bells. Now, clearly, not all Hispanic kids under 5 have TB. That's the tricky part. You got to understand what risks they have on top of it. But those are the kind of thoughts we want you to have, especially about foreign-born status.
Another thing, Scott, on the foreign-born that sometimes in dialogue is misconstrued. Remember, when a person is going to leave their country of origin, we do have a screening process internationally that the individual is screened. If they detect TB, they're treated. Latent TB, offered treatment. However, the great preponderance of the foreign-born that come to this United States are either coming under visas that expire and they stay. I mean, many of you are aware of the whole dialogue of the immigration issue, but people stay. Visitors. So visitors come back and forth, are not screened. And, with the huge influx of children that we're seeing, coming unaccompanied and their parents, obviously they haven't been screened. So you need to take your history and know how the person, came to the country.
So like Kim said, this becomes a real issue for schools, universities, colleges. As more and more foreign-born students are coming to train in the United States, this becomes a real dilemma for a school. How do they ensure that they're protecting their students in their campus? And how do you screen? Who do you screen? What's the best way to do it? a lot of these we should give you answers to by the end of the talk. This slide here shows you that states with the greatest percent of pediatric TB cases in the United States. Not unlike that map that I showed you earlier, not all states are equal. So here are some states, looks very much like the map, that have a large percent. I'm not quite sure what state is all others, but you know what that means. That means each of us have a piece of those other states if we're not from Illinois, Georgia, Florida, New York, Texas, or California. So who then should be screened for TB? And what does the American Academy of Pediatrics say about this, and what does the CDC say about this? Well, the main point of the American Academy of Pediatrics is this point of targeted testing, that limitations of any test are in using it in people that really have no risk for the disease, because not all tests are perfect. And unfortunately, I think in medicine, a lot of folks really want that black or white answer, that yes or no answer, that do I have TB or do I not? And you cannot just apply these tests that we'll talk about to the general population and expect them to be perfect. So targeted testing is the goal. And if you're an epidemiologist, you really like this because you know the positive predictive value of a test goes up as the prevalence of that disease is higher in a population. So what targeted testing does is make it more prevalent in those that you're testing so that your tests perform better. Okay, so what do they say about targeted testing? They tell us that we should screen for risk factors for TB and latent TB. Okay, so the difference we explained earlier, just to remind you again, latent TB means that you have inhaled the bug, it has landed in your lung most likely, your immune system has contained it, and you have not developed any obvious signs of disease. A chest x-ray is normal, a physical examination is normal, but a test will be positive. So it may be a skin test or an interferon gamma release assay may be positive. That is the definition of latent TB infection. And again, 10% of folks go on over their entire lifetime to develop TB disease. Unless, of course, you're under 5, your rate of progression is much higher, as high as 40% in some cases. So we should only test if there's at least one risk factor present. And we'll go over those risk factors in a minute. And that we do not do universal screening, as I explained, the test performance suffers when we do that. And that we should discourage this administrative or mandated test for any child care, school, summer camp, or college.
And I'd just like to encourage the audience of all of you as healthcare practitioners, and certainly the nurse practitioners in the audience, that this is a point you're highly recognized by policymakers, whether it's in your state or even U.S. Congress, for your knowledge and your experience with populations that you treat. Advocacy here across the nation could be used to support and discourage administrative or mandated tests, so therefore releasing resources and the focus for all of you and all those working with tuberculosis control to focus on the most at risk, as Scott will be covering next. So I encourage you to get involved.
Okay, so here are the risk factors. This is from the American Academy of Pediatrics, as you can see, that these risk factors, as we've talked about, being born outside the United States is right at the top of the list. So asking someone whether they're foreign born. Have they traveled outside the United States? Have they been exposed to anybody with tuberculosis? Any close contact with anyone who had a positive TB test or spent time in jail, homeless shelter, HIV, illegal drug use, have eaten raw or unpasteurized cheese or milk, has a household member born outside the United States, or a household member that traveled outside the United States. So this is a pretty broad risk factor screening. So when I think about my own kids, and we live in the Seattle area where there isn't a lot of TB, No. My kids are not born outside the United States. Yes. They have traveled extensively outside the United States. So they've been to Guatemala and Ecuador and Belize, and we've done a lot of international travel. So that always reminds me that your risk is not zero. And of course, as a TB doctor dad, have they ever been to a TB hospital around the world? And the answer is yes. Okay, so if you're my clinician on the phone, you should be talking to my daughter, right? Have they ever been exposed to anyone with TB? For my daughter, the answer is yes. Unfortunately, in Washington, we had an incident where we had a child with TB that no one could take care of, and I actually put him into my household. Yeah, I'm not kidding. Actually lived in my household while we treated him for TB because there was no other options for treatment. So, yeah, my child has been exposed to someone with TB. Close contact with a person with a positive TB test, yes. Spend time with anyone in jail, homeless shelter, HIV, or illegal drug use? I declined to answer that on the phone, but the answer is no. Raw or unpasteurized cheese or milk? Yes, my daughter has had it. She lived in Nicaragua for a while and did eat raw or unpasteurized cheese or milk against her infectious disease father's advice. Household member born outside the United States? No. And a household member travel outside the United States? Yes. So you can see that actually took a couple minutes for me to run through that. And so unfortunately these risk factors are broad and take some time. But this is where Kim and I really want you to focus your energy at looking at these risk factors, not just doing a test on a child.
And I just want to say that in all my years of working as a nurse, not only with tuberculosis, but in a practice, because I'm more focused on acute care now, take a look when you go back at your history forms and your medical records, and I know everybody has different systems and we can't unify the whole world on how we maintain data, but you at least for your pediatric practice should have those risk factors. There are several there, but it would save you immensely by asking these questions and not missing someone truly at risk.
And this slide here is just really a reminder slide for you all to have at your use if you need some reminder on what's the difference between TB diagnosis or the latent TB diagnosis. And again, TB diagnosis, patients are symptomatic, the chest x-ray is abnormal, or they have a finding on examination like a lymph node or bone TB or something like that. And that a sputum example or a tissue biopsy is really the gold standard for culture. For latent TB diagnosis, it's really our testing methods that give us that diagnosis. And then again, that's an IGRA or a TST. And what we're really doing is ruling out TB to find those that need treatment for the few bugs that are in their lung that give them the positive test before they go on to progress to disease. The patients are asymptomatic, their chest x-ray is normal, and again, you need a test with high specificity. The good news is there is time to sort this out, which is different than when we're dealing with TB disease. And just a reminder why it's so urgent when we're dealing with TB disease is not just because that patient is not feeling good, but the risk is they can infect other people. And that is the role of public health system to really get in and do what we call a contact investigation around active cases to make sure we find anyone who's under 5 before they develop disease or are immunosuppressed. So that's the difference between the two. What the Red Book tells us, and again this is American Academy of Pediatrics, tells us about latent TB evaluation is here on this slide. It's a good reference, and it really is talking about contacts of people with confirmed or suspected TB, children with x-ray findings or clinical findings suggesting TB. Essentially what this slide is telling us is you don't just test everybody, but if they have risk factors and they are contacts of a contact investigation, or findings, either clinical, and you're trying to sort out whether it's disease or LTBI, this is a good LTBI evaluation reminder.
Just want to say that with the contact investigation mentioned in the LTBI evaluation, again, one of the communities I was working in, they have strictly gone in school contact investigations to on-site using the IGRA. And any of you that are school nurses out there or have worked with contact investigation, to immediately be able to, draw the specimen and not have to depend on reading a skin test in 48, 72 hours, not only is really assurance that you're going to be focused on your investigation, but that you're going to identify truly those at risk and begin treatment if needed.
So what does the CDC recommend for screening for tuberculosis in children? There are really two classes of tests, and we'll talk about these in a little bit here. One is the TST is the preferred method according to the CDC. The IGRA is acceptable, especially in kids under 5. I know one of the more common questions I get is, can you use an IGRA in a child? And the answer is, of course, yes. And it is not FDA disapproved in children, as most people think. It actually is okay to use in kids under 5. It's just these are the CDC recommendations of the TST being preferred and IGRA being acceptable. So I would not hesitate myself using an IGRA or a TST, depending on the individual and what I'm trying to sort out, either of these two tests in any age group child. While routine testing with a skin test or an IGRA is not recommended, thank you, CDC, they're very clear on this, results from both tests may be useful in the following situations when the initial test is negative. Okay, and so this becomes a question I get all the time. Someone has put on a skin test and it's negative, but they did an IGRA and it's positive, or vice versa, and those two tests aren't. The real recommendation is not to mix these tests. But what this situation is saying is when the risk of infection, the risk of progression, and the risk of poor outcome are increased, like kids under 5 or people with HIV infection, you can use these two tests. They may be useful. But you got to be ready to explain the difference between the tests and which one do you trust. So what TB screening tests are available in the United States? And really, there's three initial TB testing methods. There's two methods for looking at interferon gamma release assays. And they're in the pictures here that you can see. And of course, there is the TST, or the skin test, that many of us are familiar with. Both these tests help differentiate persons with Mycobacterium TB infection from those that are not infection. But a negative reaction does not necessarily exclude the diagnosis of TB or latent TB infection. I have to tell you, in my career, some of the worst cases of TB, the most fulminant cases in foreign-born kids with very clear disease, had negative tests. TST at that point was negative in one child with fulminant pericardial TB from the Philippines. So here's my advice. No test is perfect. And no test alone should help you make a decision about whether someone is infected or diseased. It is an important part of the entire armamentarium of analyzing kids for their risk of TB. Again, I tell you all, the epidemiology is one of your most important tools in differentiating. Any of these three tests can be used. They have limitations. They have advantages, and any of these can work along with your epidemiology. And we'll go through these. Recently,
in an acute care setting where I was employed, and they happen to know I do TB, but the issue represents what Scott's saying. Very good that they identified someone they felt was at risk. They applied an IGRA, came back negative, but because of their risk factors, they collected sputums. They discharged the person before the sputums, so they had a negative IGRA, collected sputum, discharged them to a nursing home, by the way, and what do you expect? The sputums grew out. So it's just a point that it is not the test to diagnose disease.
Right. So here on this slide, I list some of the pros and cons of either of these testing methods. And certainly working in the public health system, no two patients are alike. So one of the pros about the skin test is the initial cost of that test is less. It's cheap. So when I have someone come in who's foreign-born and they do not have insurance and they do not have money to pay for their evaluations, maybe it is an acceptable method to use a skin test, as long as you know the limitations of it. Okay, so I know it's not a perfect test, but sometimes the cost is a major driver. Now, on the other side is the IGRAs. While the initial expense can be higher, a lot of the cost-effective studies show us that because of specificity and sensitivity differences, that it actually may be cheaper in the long run and more cost-effective to use one of the IGRAs, which is something I believe fairly strongly. Another con of the skin test is that it really requires 2 visits. And this becomes a problem if you're doing an outbreak investigation, say in a homeless shelter. And you have to find someone who is homeless twice, one to put on the test and one to read it. That's pretty tough. It's a lot easier when you have a single visit. So Kim and I have been involved in outbreaks in IV drug abusing communities, and the value of a single visit test is wonderful. The skin test, one of the cons that we run across is just human error, that there's some bias. So as many of you on the phone know, you get calls where someone thinks it is 10 millimeters, someone thinks it's 14, someone thinks it's 15. How do you know which is correct, and all the effort that goes into limiting human error and bias?
I might add there, too, that when I was here for the years as the state tuberculosis controller, I was invited always by the University of Washington to their ambulatory care conference each year, and they'd have me do a update on TB, but they'd also have a practicum on tuberculin skin testing, and there'd always be about 50 to 70 people there. I cannot tell you how many times a person would say, I never get the little, wheel, and therefore, if you can't get the wheel, as you know, there's the issue of you're not probably going to be able to interpret it. So it's just fascinating to me that the tuberculin skin test has been as long as it has, but you have to remember who taught you first how to administer and interpret it, and that's where that human error and bias comes in.
And a reminder to everyone, when we're reading tuberculin skin testing, we're reading the induration, not the redness. So that's always a reminder to tell people. I personally use what's called the pen, P-E-N, method, where I run a pen. I try not to look at the induration, and when the pen stops, I make a mark and come from the opposite direction, run the pen till it stops because it bumps into the induration, and I measure that distance. That is something that helps. I think it's a good reminder if you're using skin tests to review how you're placing them, review how you're scoring them. And again, we don't call them negative or positive. We report them in the number of millimeters of induration. So a skin test will be reported as 3 millimeter or 15 millimeter. And of course, those numbers mean different for different folks with different risks. Okay. That's different than an IGRA, which comes as a positive test or a negative test. Now, occasionally you'll get an indeterminate, but those values are pretty low. It is not something that happens often. And it's usually 1% or less, depending on the lab that does it. But boy, there's something sweet about a positive or negative test result that makes it's automated and it's easier to read. And the other value is it gives you a positive and a negative control, which the skin test, of course, does not.
I'd like to say there, too, in all the clients that I have screened with the IGRA, when they get those results, there's something more affirming to them rather than someone touching their arm or not touching their arm. They're used to laboratory information, and this seems to be credible to them when they have this information.
Now, with the skin test, this is really a difficult thing to evaluate how sensitive or specific a test is. We'll go over some of this science in a couple slides here, but there is variable sensitivity and specificity of this tuberculin skin test. The sensitivity and specificity of the IGRAs appears to be better. Not all studies are supportive of it being massively better, but there is a good body of evidence as we're accumulating is showing us the sensitivity and specificity of the IGRAs to be improved in some cases. And where there's exceptions, I'll talk about those in a minute. The problem, one of the biggest problems for me with the skin test is that it reacts with BCG and Mycobacterium other than TB. That's what MOTS means, Mycobacterium other than TB. And that's a problem because who receives BCG? And that is foreign-born folks. So in a foreign-born evaluation, if someone has had BCG, it can create a problem. Now, not everybody that gets a BCG has a positive TST. It's not universal. And it, of course, depends on how long ago that BCG was placed and other indicators in the individual, but it does react with BCG, and that's one of the things that the IGRAs really pride themselves on, is it does not cross-react with BCG. So hold on to that concept as we go through some of this later. As many of you know, we've had a shortage of supplies for tuberculin skin testing, and for us in Washington State, that creates a real problem when we have some of these rules for like daycare or for adult family home, and we have a shortage of these supplies. But, you know, this list isn't inclusive, and it isn't meant to make one of these tests better or worse than the other. You just, as I said earlier, when you're facing that individual, you have to understand the pros and cons of the testing method you're going to use.
It brings up a valid point what Scott mentioned about supplies and the administrative screening. Often the guidelines or guidance or policies have not been changed to include the IGRAs, and so the tuberculin skin test is still the predominant.
So what are those recommendations from the American Academy of Pediatrics or the CDC regarding IGRAs? And it's a complicated story. No story is ever super easy, and so I want you to understand it. Really, the recommendations of the American Academy of Pediatrics about the use of IGRAs in kids back in 2009 said that IGRAs may be useful in kids who had received BCG. Well, that makes a lot of sense to me, but cannot be routinely recommended in kids under 5. Okay. Much of that recommendation was because there wasn't a lot of experience. This was a newer test. So I am not the most patient person in the world. I have been waiting anxiously for this data in kids under 5, and we'll talk a little bit about that. But in 2012, as the picture is evolving, it became an IGRA is preferred, a TST is acceptable in kids greater than 5 with BCG. So that statement becomes a little bit stronger, and a lot of that's based on does this test react with BCG or not, or for those who are unlikely to return for a TST reading. And we talked about a couple populations, IV drug use, contact investigation at a homeless shelter. But TST is preferred. IGRA is acceptable in kids under 5. So that's kind of the evolving picture. What does the CDC say about the use of IGRAs in kids? In 2010, the IGRA guideline was really, as you see here, an IGRA is preferred for testing persons who have had BCG. A TST is preferred for kids under 5. And so that's a real dilemma. Imagine you're under 5 and you've been vaccinated with BCG. Which test do you use? Okay, so let's look at the evidence here. And this it isn't totally inclusive. There are some good meta-analysis sense that we'll talk a little bit about, but here's a good summary slide of looking at sensitivity and specificity of a test. And here are some of the bigger meta-analyses that have been done. Since this, there's actually been a study by Mandalakis from, of course, my old haunting grounds, and didn't see quite as big a difference between the sensitivity of the T-spot, the quantiferon, and the skin test. And so there's still some dilemma out there that is the interferon gamma release assays that much better than the TST in kids. So here we have a good meta-analysis looking at sensitivity that shows this T-spot and quantiferon essentially the same here, 84.5, 88.5% versus the skin test, which was really 71.5%. So here's one of the problems. How do you use a gold standard to determine which test really predicts whether someone has disease or not? Because we've always had the skin test, but that cannot be the gold standard if you're comparing it to others. So in these meta-analysis, a lot of the gold standard was not latent TB infection, but rather does the person have tuberculosis? And in the person that we know has tuberculosis with a culture-proven TB, how does the T-spot, the quantiferon, or the skin test perform? And that's where a lot of this data comes from. And I think the general trend here is that in folks with disease, in these meta-analysis, that the IGRAs appear to be sensitive, certainly equal to, if not a little better than the skin test, and then specificity, so the other side of the coin, when it's negative, that some of these studies didn't actually look at the skin test. They may have looked at the T-spot or the quantiferon, and those are fairly high numbers, anywhere from 86 to 96%, compared against the skin test, which was around 59%. But you can see there's some variability. This PI study in 2008 showed not as big of a difference. So, you know, as clinical epidemiologists, we have to be aware that some studies don't show the same difference. One of the more interesting recent studies I've seen, and I've been waiting for very impatiently, is kids under 5 and how good does the interferon gamma release assays perform in those kids under 5 for latent TB infection. And the study is a recent study. It was done this year, and their bottom line is that their meta-analysis shows that sensitivity and specificity were slightly higher than the skin test. So there you go. You get in a kind of a mixed picture here of some studies that show a good difference and some studies that may or may not show a large difference. Mandalakis, PI, some of these studies. My point to all of you is that it certainly isn't showing that the skin test is useless. It certainly isn't showing that IGRAs perform less well than the skin test. There's some variability here, and certainly what comes out is that BCG affects the skin test performance, and that IGRAs appear to be more specific, and in these meta-analyses a little more sensitive.
And I guess always incorporating, no matter what methodology you use, in a risk assessment for screening. Because if we're looking at the risks, then we're more adequately going to not depend on the test to diagnose, but we're going to look at all the symptomology and the history of the patient before you proceed.
We've included some references here to help you get a handle on some of these concepts that we've laid on you today. And at this point, Corey, would we like to open it up for some questions?
Yes, absolutely, Scott. We had a few questions that came through, and still at this point as well, if you still have another question you'd like to ask, just a quick reminder, you can just click on the Q&A box just above the presentation, and you can type in your question and then click Submit. The first one we had that came through here was, in our practice, we made a big deal about how long someone was out of town. If it was greater than 2 weeks, then we tested them for TB. Does this still matter, and what if the patient is at a resort that's in a TB endemic area?
Yeah, you know, this is something I struggle with quite a bit too. Not all foreign travel is equal. That's the point. And I think there's not going to be hard and fast guidelines. You're going to have to use your own judgment as an epidemiologist of what is at risk. So certainly my family going to the beach in Mexico, is fairly low risk. That wouldn't necessarily mean we're at high risk, but my daughter going to an island and living with families where there is TB in the community for several months on end, that's a lot different. So, there's no hard and fast on this. It's fairly gray.
And I might mention on a recent follow-up of a case and its contacts, the child had traveled to another country. The child was under 5. And the question, remember, it's the questions that we need to ask of the adult caring for that child. They never asked, who were you visiting and was anyone ill? And the reason for the travel was to visit a family where the grandfather was ill with tuberculosis. So it doesn't mean that someone's going to come right out and know that they've been exposed.
Yeah, but I know people want really clear guidelines on this, and unfortunately, this is the world of TB, and there are no black and whites on this. And whenever I kind of use this general rule, here's my food rule. Are you ready? When in doubt, and you're cleaning out the refrigerator, throw it out. So when in doubt, throw it out. For TB testing, when in doubt, do the test. That, when I do the test, means I understand what I'm going to do with those results. I understand the limitations of the testing method I'm going to use. For example, if it's a BCG vaccinated kid who I'm going to use a skin test because they can't afford or don't have money to pay for something, I understand the risk of that, and I understand what I'm going to do with the result if it's positive or negative. I have thought this out before I've done it. So that's the only thing those are my 2 general rules about TB and certainly bad food.
If one or both the parents are born in Mexico or outside of the U.S. but have lived in the U.S. for 15-plus years, will you consider that as a risk factor for the child?
Yeah, if you had asked me this 20 years ago, I would have said, yeah, you're from Mexico, it's a risk factor. But not all folks from Mexico are at high risk for TB. And certainly the risk goes down as you've been in the country longer. Most folks, if they've been infected, have active disease within the first 5 years. That's kind of a general rule. So it's not high risk, but there's still some risk there. I would ask questions to clarify. Has anyone in the family ever had TB? Grandma, grandpa, uncles, aunts? And has the child traveled back home to see the grandparents or uncles, aunts, or anything? And if you're getting a sense that there is some risk within the family, either in Mexico or in the United States, then yes, I would test.
And also, has the family from the other country traveled and stayed in the home here in the U.S.?
So it takes a little more settling out this question.
So if a child is starting kindergarten and there are no risk factors, will you still recommend TST? What if their school requires PPD, but you suggested to discourage administrative requirements for PPD? Should we or should we not administer it?
Personally, I do not. But what it means is 10 times the amount of work. Because what I end up doing is explaining to the family, it takes time to explain to the family why you're not recommending a skin test or an IGR in this case. Because the child is not at risk, I share with them the American Academy of Pediatric Recommendations, but that doesn't solve their problem. Their problem is they have an administrative requirement for the school, and so that usually requires me going to the school or talking to the school or writing a letter to the school. Believe me, it's better done in person, and really explaining and showing the American Academy of Pediatric Recommendations on this and explaining why the test isn't a good use in folks that are at low risk. And, most folks get it. They've just never had someone like us as providers explain to them. And we are currently in the midst of rewriting all of the TB law in Washington State. So there's a lot of laws like this that are based on tradition, not based on science. And when you take the time to share these recommendations, it actually goes pretty well. And I know we as clinicians don't have a lot of time to do that, but that's my answer. That's the best thing to do. It's as Kim said earlier, people respect you. As the provider, they respect your opinion on this, and they usually welcome your advice.
We have a few questions here related to IGRA. Am I pronouncing it or saying it correct, Scott? I just want to make sure.
Yeah.
Gotcha, yeah. So if a child is found to have a positive IGRA treated for latent TB, complete the course of treatment as follow-up tested needed. Will future testing always be positive?
Okay, so again, there's no black and white answer to this. One thing that we know from some studies that have been done, there's this great set of studies that looked at people that had a positive IGRA that went on treatment. They actually had active disease, and they followed their IGRA levels, and the hope was as you were treated, those levels would go to zero. But unfortunately, that has not been the case, and it looks pretty much, and it's affectionately termed spaghetti. Those numbers are all over the map, so you cannot use a follow-up test to ensure adequate treatment. So the answer to that is if someone who is 5, you said 5, right?
I believe the previous question was talking about kindergarten. I don't think there was a specific age mentioned in this one.
Positive IGRA, and they receive adequate treatment, which, as a reminder, is INH or rifampin, depending on a lot of factors. Like, how do we even know that the strain that infected the child was INH sensitive or rifampin sensitive? Because a lot of times we don't have the source case. So you're kind of out on a limb in the first place. And the best we can do is identify them with a positive test and risk factors, and then treat for the course, which is 9 months. And then the best we can do is remind those families that your child had a positive test, the efficacy of the treatment is good, not perfect, and that if this child develops any symptoms in the future, cough, night sweats, weight loss, that they should be aware and evaluated. Now, for the most part, if you have a positive skin test, it's going to be positive for the rest of your life. It's not 100%, but that's a good general rule to apply. For the IGRAs, it's variable. Because you have a positive IGRA does not mean you will have an IGRA positive for the rest of your life. But like the study showed us, there's not a good correlation between IGRA positivity and treatment or not. Maybe in next generations of our blood testing will get to that, but currently now it's still a gray unknown.
So if cost and resource were not a factor, would you recommend IGRA to all children entering school?
No, I would not recommend to all children entering school. I would recommend an IGRA for anyone that had risk factors if cost is not an issue. Personally, I am comfortable with the pros and cons of an IGRA, and I can explain them and understand them and predict them so that I'm comfortable. And I have tried to go exclusively to IGRAs, and I understand, of course, I understand the science and the data, and I review all the most recent studies. I'm comfortable with IGRA in anyone who's at a risk factor. I'm not comfortable using an IGRA in someone who doesn't have risk factors.
And in contact investigation work that I've done with the IGRAs, and again, this has mainly been in a high school setting, it has really worked well, and those that were positive really had other risk factors other than even being a contact. So again, it is currently being used in school population as contact investigation work.
All right, so we are at the top of the hour, but we do have time. We can maybe run through another couple of questions here, but if we do not happen to get to your question, we do have the contact information of folks that have submitted questions, so we will try to get back to you via email as far as an answer for your question. The next one coming in, for our children with risk factors, how frequently do you recommend testing? Is it maybe yearly or how long?
Yeah, that depends on what the risk is. If a child has a risk, say they're foreign-born, but they haven't traveled, and you test them for that entry to school or whatever, college in the case of my daughter, and their risk doesn't change, there probably is not a lot of value in routine testing. In a situation where your child may work in a healthcare setting, so a lot of kids volunteer in the hospital, doing that initial test if they have risk factors, and then if they're working where they're exposed to a case, and that the prevalence of TB in their hospital is high, or they're exposed to cases, or they've traveled since then, yeah, then I would test annually. Personally, you know, the proof is in the pudding. How often do I get an IGRA? I do it at least once a year. I have never had a positive skin test either, but I do my IGRA once a year. Of course, I see active cases. If I was exposed and I wasn't wearing a mask, or I was surprised by something, I would probably test, you know, more frequently. But myself, I test annually. But my risk is high. My daughter, she can get screened when she goes to college this fall. And then unless she is doing a lot of international traveling, which she cannot afford, by the way, if you see her, then she really wouldn't require a test annually like her father.
And again, remember in the risk factors and questioning, people do a lot of volunteering today. So it could even be volunteering in food banks or serving the homeless population. You know, any of our high-risk category population, if the person is being exposed to that group, would be another indicator.
All right, so our last question here, how many years post a BCG are you comfortable administering a TST?
Well, it depends on when you talk to me in my career. If you talk to me 20 years ago, I would use data that showed usually within 5 years the rate of TST positivity started to wane after about 5 years, and certainly 10, 15, those numbers become negligible. You talk to me now that we have this technology of an IGRA that does not cross-react, why would I use a skin test in that population? I don't even need to bring that into the equation. I just use an IGRA. So I don't really look so much at that data anymore. Again, for everyone on the phone, just because you had a BCG does not mean 100% of those people will have a positive skin test. Those numbers fall over time, and certainly within the first 5 years is the highest rate. But again, now that we have this technology that doesn't cross-react, I don't really even go there anymore.
And for a lot of you out there working with pediatric population, remember the children that are adopted from areas of a high burden of TB. It would really be, probably the priority to use the IGRA.
All right, so that is all the time that we have for questions. Once again, we will do our best to reach out to the folks that did not have their questions answered with an answer for you, so keep an eye out for those. But on behalf of NAPNAP, I would like to give a special thanks to both Dr. Scott Lindquist and Ms. Kim Field for their commitment in developing today's presentation, and also an excellent job in presenting that as well. I'd like to thank everyone for their participation in the webinar today. A lot of great questions. After you exit the webinar today, you may notice in your inbox that there is an email. I believe it already has been sent out, at least that I saw it, to the email address that you registered for today's webinar. In that email, you will be getting directions and a link on how to access the survey that we mentioned at the very beginning of today's presentation, as well as the certificate that you will receive upon completing the survey. We appreciate all feedback that will help NAPNAP plan future web events. If you do have any questions regarding today's webinar at all, please feel free to call NAPNAP at 1-877-662-7627. Just one more time there is 877-662-7627. You can also visit www.napnap.org or email us at info@napnap.org. Thank you again, everyone, for attending today's session. And at this point, that concludes, and you either can disconnect or sign out. Thank you very much.